Okay, here we are for the final regular lecture of the semester. I'll be doing another video that has a review for the final, but the female reproductive lecture, final PowerPoint, final lecture. I have changed this PowerPoint some in the last couple of days, so if you printed it out previously, that's fine. You'll find that a few slides are missing. I took out some slides that I felt were redundant. They were supposed to clarify more, but for this kind of a presentation, I would rather not have more mess and have it be as succinct as possible. It's a fairly long lecture anyway. So we're going to talk about the female reproductive system. We already talked about differentiation, so that if you don't have the hormones to become a male, you stay a female. So you don't have to move the ovaries. They stay where they are instead of dropping down and becoming testes. You don't have to grow external genitalia in particular like you would if you became a phenotypic male. And so we'll talk about that a little bit, but largely we'll talk about the development of the female in utero, the reproductive cycle, starting with puberty and then moving on through the time of menopause. And we'll talk about what happens during pregnancy and lactation, or producing milk. Hello, here we go. Okay, so oogenesis. The oo is the egg, so an oocyte is a egg cell. Oogenesis and hormone production, just like in the male where you have to make both sperm and hormones like testosterone, in the female you have to make the egg and hormones like estrogens. More different hormones that especially support the growing fetus if you become pregnant. So we'll talk about the hormone production and how you develop the different structures leading up to gestation, the monthly cycle, in other words, your menstrual cycle. Then during gestation, if you wind up getting pregnant, puberty and sexual function, what happens when you become sexually mature, pregnancy, childbirth, production of milk, and then menopause. The female reproductive cycle is largely hormonal. Everything is driven by hormones. When this hormone comes, you produce an egg. When this one happens, you produce thickening of the endometrium so that you can get implantation. When this one happens, you make milk. When this one happens, you release milk from the breast. So it's going to be a lot of hormonal stuff. Now, genetically, if you're a female and the ovaries stay in position and mature into regular ovaries, remember, you won't have testosterone, so you'll lose the male tubes. You also won't have anti-Müllerian hormones, so you keep the female tubes and the development of the uterus and vagina. So at the beginning, when you're an absolute beginning female embryo, you have about 7 million primary egg cells. That's the most you will ever have in your life. Your body is designed just like the male hormone, male sperm. You have to have millions of them, and they swim and swim and swim, and only the most powerful wind up reaching the egg. You start off with 7 million eggs, and only a few of them wind up being strong enough and to mature and become and ovulate and have a chance to be fertilized. So the whole process is designed to be survival of the fittest, to give you the best chance of having a viable and strong child as possible. So you start off with 7 million. At birth, you've already cut 5 million of the weakest ones out. you have about 2 million. But by puberty, most of those are gone too, and you start off your reproductive years with about 400,000 potential eggs, way down from 7 million. And of those, only 1 in 1,000 will actually be ovulated. So every month you will have a group of them that tries to become the most powerful, but only one, usually, 2 occasionally if you have twins, but only one of those will win and mature, and the other ones will simply be reabsorbed. So here it is. Here you're fertilized, your egg is fertilized. Very soon you proliferate, make just a ton of primary oocytes. And then they start breaking down, the weaker ones. At birth you have this many, but at puberty you have dropped all the way down to, 400,000 or so. And then each month you will produce a few that will try to become the primary oocyte and, get fertilized. And that will reduce and reduce and reduce. You don't make any more eggs. Males make sperm throughout their entire lifetime. It may change amounts a little bit, but the female starts off with a ton of eggs, drops down, keeps only the strongest ones, and these are the only ones you'll ever have. Each month, maybe a dozen of those primordial eggs, primordial egg cells, they try to develop. They're the best ones you've got right then, and of those, almost always, only one of them, it's like a litter where only one of them is strong enough to get fed, becomes the Graafian follicle, and that means that one has beat out everybody else and becomes the one that gets to try to get fertilized that month. Of course, most of them don't either. Usually you menstruate, you don't get pregnant every month. And so, but at least there's one that is the strongest one you were able to produce that's maintained. The others are simply reabsorbed. Now, the primary follicles are genetically produced. You don't need any hormones for those. So those 7 million you have, and then they fight to be part of the 400,000, that's fine. But during the monthly event where you're trying to take some small group of those and make yourself a primary follicle to become a Graafian follicle and go out and actually become fertilized, this is stimulated primarily by follicle-stimulating hormone, FSH, coming from the pituitary. So it turns these primary follicles into more substantial follicles that have a chance to develop. Then you have a group of theca cells, which are the female equivalent to Leydig cells in the male. Remember, LH stimulates Leydig cells, and it makes hormones, testosterone and dihydrotestosterone. Theca cells are the woman's version. They are stimulated by luteinizing hormone, also LH, and they secrete testosterone, which immediately is converted mostly into estrogens. And they will form together to create the outer capsule of this Graafian follicle. The most powerful cell gets surrounded by some granulosa cells, but mostly thecal cells, which are going to secrete the hormones that you'll need for that cell to mature, get fertilized, and implant in the uterus, if that is to be its fate. Theca cells, like Leydig, LH, hormones. The other type of cells are like your Sertoli cells in the male. Granulosa cells, they are around the area, and they help the stimulation of the formation of these primary follicles into better follicles. So remember, Sertoli cells in the male, stimulated by FSH, and stimulate sperm, SSS. Here we have granulosa, stimulated by FSH, and they're going to make your primary follicles, the granulosa cells are going to help produce the primary follicles, just like Sertoli cells make sperm. So S, sperm, S, the female follicle, FSH. Those are your two primary kinds of cells other than the eggs themselves. Just like the male has Leydig and Sertoli, female has theca granulosa cells to do the two jobs. So here we have the primary oocytes. They're being they're genetically produced, and you have 400,000 of them. They're small, and they start to grow. A little group of them starts to grow, and one of them wins, and it becomes surrounded by some Sertoli cells, but mostly theca cells, because these are going to have to secrete hormones that you're going to need. This layer of theca cells around here is called the corpus luteum, and this is the luteal phase, stimulated by luteinizing hormone. LH, corpus luteum, is produced, and it's full of theca cells making hormones. When you ovulate, the egg pops out with some of these around it, but it leaves a big blob of those theca cells behind. Strictly called the corpus luteum after the egg is gone out of it. This will, for the next several days, produce lots and lots of hormones that you need to keep on to maintain the endometrium, to build the thickness of the endometrium so it's ready for implantation if you get a fertilized egg. This corpus luteum will last for several days, and then it will lose its pizzazz. And at that time, if you haven't fertilized the egg and implanted it and started the next part of the process, you menstruate, and it all starts over again the next month. Here we have an ovary. Where's my thing? Here you have the ovary. Here we have the follicle surrounded by the thecal cells. The follicle is going to squirt out here, leaving the corpus luteum behind, producing all of the hormones that are required to support the reproductive system cycle if the egg gets fertilized. Now here are the ovaries once again. The ovaries are going to produce this egg. It will ovulate in the general direction of the uterine or fallopian tubes with the fimbriae on the end. The egg will float free in the abdominal cavity briefly until these fingers of the fimbriae pull it in, and then you have cilia along here that will move the egg along. It will have to get fertilized about here if it's to develop enough that it can implant by the time it reaches the uterus. So, the ovarian cycle, or the menstrual cycle, the ovarian cycle, the luteal phase, first LH stimulates the corpus luteum to produce a lot of hormones that you need, primarily progesterone. Estradiol is another one of your estrogens that also will play a role. But for me, progesterone, when progesterone is higher than anybody else, you maintain your endometrium, you maintain a pregnancy, you don't menstruate, and you don't induce early childbirth. Progesterone is the guy that's got to be elevated to prevent you from menstruating and losing the egg or having childbirth too easily. So LH stimulating the corpus luteum to produce progesterone. Now, when this happens at this point of the cycle, LH goes way up at the time of ovulation, so this corpus luteum can start making a whole bunch of progesterone. At that point, the progesterone spike causes an increase of temperature, your body temperature. If you're 98.6, suddenly you're 99.1 for a period of time. That's when women take their temperature to see when it's time, when their ovulation has occurred, because you have to fertilize that egg preferably in the next 24 hours. 24 to 48 hours, but mainly 24 hours is the time. So the wife is taking her temperature regularly, it spikes, and she calls hubby at work and says, better hurry home. We want to have Junior. So that's the LH causing the corpus luteum to produce a lot of progesterone, causes this abrupt spike in temperature, and causes the endometrium to be sustained. If the egg is fertilized, you're going to need more LH, and there won't be enough LH making it to the fetus as the corpus luteum drops down, and you need to make more progesterone, you need more LH. As soon as the embryo implants in the uterus, it immediately starts growing its own placental unit. And as I mentioned before, one of the first things it does, it starts making substitute LH, human chorionic gonadotropin. Part of the chorion part of the placenta is called the chorion. So as soon as it starts growing, it makes this gonadotropin, which replaces LH. So human chorionic gonadotropin is released so that you don't menstruate and you keep on growing the fetus in there. It's a pretty close timing. And once again, human HCG is a good indicator that you're pregnant, because unless you're growing the chorion or placenta, you won't make any HCG, and you'll go ahead and menstruate and start the process over again. So now we have to fertilize the egg. We've released the egg, and it's in the early area of the fallopian tube. So we're going to have to fertilize the egg if we want to have a baby. The desire for sexual activity in males and females is actually increased by testosterone, interestingly. Estrogens maintain everything that is needed here, and they cause more vaginal secretions, which is why women after menopause often complain of dryness in the vagina. So you have a little spike of androgens, and then a lot of it converts to estrogens. But during this spike, the woman is more interested in having sexual activity. Then the sexual response is very similar to the male. Parasympathetic causes the erectile tissue, the clitoris, and the opening of the vagina to become more stimulated, more engorged with blood. It increases vaginal secretions. So this is equivalent to the erection in the male. The female orgasm is with the male is sympathetic and somatic. I didn't put somatic on here, but some of the sympathetic is an automatic response, which is most of it, but somatic too for some of the contraction, the pulsations of the vagina, fallopian tubes, the uterus, in an attempt to move the sperm toward the egg and move the egg toward the sperm. The cervix dilates and stays open, so the sperm can enter more easily. Now here we're trying to get ready for this egg to be fertilized. Okay, I'll show you this a little bit. Let's look in particular at LH and progesterone. LH and progesterone. Those are the two I care about the most. Now, estradiol, remember that other estrogen goes up some to help, maintain secretions and stuff. But what really causes the ovulation to occur is an LH spike. Remember, LH, it causes the egg to leave the corpus luteum, and then it causes that corpus luteum to be maintained so that it can release a lot of progesterone. The corpus luteum releases progesterone. Progesterone stays high until you have time to find out whether you fertilized your egg or not. And if you don't, progesterone drops down and you menstruate. So LH spike causes ovulation, maintains the corpus luteum. The corpus luteum produces progesterone, which maintains the system so that implantation can occur if you fertilize the egg. Here's the uterine cycle. The estrogens that go up some start causing the endometrium, which is pretty thin at the beginning, causes the endometrium to thicken. And then you get that LH spike right here. It causes ovulation. And then the progesterone maintains the endometrium and stimulates it to start secreting some hormones of its own, all of which will help prepare it for implantation of the embryo somewhere along here. And then if the progesterone drops down, the whole endometrium breaks apart, sloughs off, and you go down to the in-between really thin layer of endometrium. Another thing that happens when that estradiol goes up and starts making the endometrium thicken a little bit, or quite a bit, I guess, is that it causes an increase in secretions, vaginal secretions, producing an alkaline mucus that is thinner, that the idea that sperm can swim through. And at that time, if you take a swab of cervical mucus and put it on a slide, it has a particular property that makes it produce this, they call it ferning. You can see it looks like a fern leaf. A ferning action, and that can tell you that you're about to ovulate, because the estradiol has caused this change in the mucus to be receptive to the sperm if it gets there. So this is another way of telling if you're close to a good time to try to reproduce. Okay, let's look at some of the times that you go through reaching these reproductive years. We know that the embryo has a ton of primordial follicles. You have quite a few at birth. That goes way down at puberty. At puberty, you have your 400,000 primary oocytes, but you've also reached the FLH and FSH increase enough that you start producing a lot of estrogens, which matures your reproductive organs so that you can start the reproductive cycle. Meno is the term for menstruation. That's why menopause means you're not having them anymore. Menarche, the term arche is like archaeological, means the first, way back in the beginning. So your first menstrual cycle is called menarche. Then your reproductive years, starting at puberty, 12, 13, 14 years old, depending on who you are, sometimes as early as 10 for some women, until around age 50, 52. I think 52 is the most common or the average age of the beginning of menopause. Here we have over the course of your lifetime, the increases in FSH and LH. And then around the time of puberty, suddenly this amount of increase reaches a threshold and you start making more estrogens, estradiol, and it causes a maturation of the reproductive apparatus so that you can start menstruating. You have a growth spurt, breasts start to develop. Here you can see early in gestation, a lot of hormones. Right at birth, a burst in hormones like you have in the male. Then everything stays pretty low until puberty. And then you start your reproductive cycle, which especially your LH, FSH, goes, your luteinizing hormone in particular, goes up so you can ovulate, goes down, goes up so you can ovulate. Every month you're going to have these spikes until you reach menopause, in which case the LH and FSH they'll continue to try to go up to force you to make more estrogens, but your ovaries can't make estrogens anymore. So these guys stay high for the rest of your life, even though you're not making many estrogens anymore. Menopause, around the age of 51, 52. Still have a few follicles remaining. You don't run out before menopause, but not many. Estrogens dropping off and the change in hormone levels does a couple of things to females. The cardioprotective effects of estrogens have kept women's LDL cholesterol lowered compared to males generally. It has maintained vaginal secretions, so when at menopause you're likely to have vaginal dryness. It also removes protection from bone loss, and so women become prone to osteoporosis. They start off with less bone material to begin with because their bones aren't as heavy as males, and then they start losing calcium a little faster at this point, so women are more prone to osteoporosis than males are. Estrogen replacement therapy used to be real popular. You'd say, well, it'll maintain all of this, and it does to some degree. But the estrogen replacement at this point, when your body is not designed to have it, has a tendency to cause blood clots and strokes and heart attacks and stuff. So it really turns out that it's not as beneficial as they thought, and it's not as popular as it was. Okay, so what happens if all of this stuff works and you actually are trying to get pregnant and you actually do get pregnant? LH spike, ovulation, maintenance of the corpus luteum, keeps progesterone high so the endometrium gets thick and stays thick so it can receive the egg if it's fertilized. So at this time, you have to have plenty of sperm reach the egg. Remember, millions are in the ejaculate. Even 20 million isn't enough. Only a couple of hundred sperm actually make the trip all the way to where the egg is, and you need that many to break through the wall of the egg. That's why, if you drop this down and you only have 25 get there, you'll never become pregnant and you're infertile. 20,000 or less. You need this many because the acrosome is an enzyme on the surface of the sperm that starts breaking down the outer shell of the egg and allows the sperm to move inside. Once the first sperm goes through, you immediately change the egg shell and make it impossible for additional sperm to come in. Excuse me. So you have one sperm. If you get two sperm in there, you'll have birth defects, which are usually lethal, because you'll have one set of female chromosomes and two sets of males. And it's impossible to live with three whole sets of genetic material. Here we have the eggshell. Here we've got a couple of sperms stuck on there. Penetration of the shell, zona pellucida. Fusion means that it's actually getting inside and releasing its genetic material so that it can combine with the genetic material in there, giving yourself an egg that now has all the sets of chromosomes that a human needs, and at that point the egg is fertilized. Ovulation occurs. Corpus luteum stays behind, making the hormones you need to maintain the endometrium. The egg is pulled into the end of the fallopian tube. Fertilization occurs within 24 hours because now the egg is going to have to start dividing and dividing and dividing to get ready to implant as an embryo. A fertilized egg is called a zygote. Then it splits again, splits again, splits again, splits again. By the time it gets here, it has several hundred cells and is called a morula. The morula starts converting itself into a blastocyte, which is, you've got the embryonic body here and an egg yolk in here, which supports the growing embryo until it can start getting food from mom. That will implant and start the process. Now, I don't care if you memorize all these, okay? You fertilize the egg, it's called a zygote. That's good to remember. The morula is the ball of eggs that's going to come in and implant. That's worth remembering too. Okay, here we have it once again. Fertilization really early. It becomes a zygote once that fertilization process has taken place. Splits the morula, and then it starts differentiating some, embeds itself, and this is about when it needs to embed. If you fertilize too early, it's going to develop too soon, and you might actually wind up with a tubal pregnancy. It might try to embed here. If you fertilize too late, it won't be capable of embedding, and you will not start making your new hormones. You'll menstruate, it'll go out, and you'll never even know that you had a fertilized egg. Here we have implantation. It binds. It starts immediately. This is actually going to be the placenta. Immediately, it starts producing this placental material, which is going to support the growing fetus. And this is fetal material here. This is mom out here. Here's the fetal material. And it's going to immediately start secreting human chorionic gonadotropin so that you can maintain the endometrium and not menstruate and lose the pregnancy. Here you have the absolute basic embryo. Okay, here you have this is going to be actually the spinal cord area, and here you've got the yolk sac here, which is feeding everything until you can set up your own fetal circulation, which is next to mom's circulation. Here are mom's capillaries, and they open into these sinusoids that are kind of like in the liver. So there's plenty of blood here, really close to the fetal blood system. It is a separate blood supply. Some things can move back and forth, antibodies and some things, and certainly oxygen and nutrients, but blood cells don't interchange. So you're not mixing blood between here and here. At that point, your brand new placenta starts making this human growth chorionic gonadotropin, which acts like LH to keep progesterone levels high so you can maintain the endometrium and not menstruate too soon. You make a placental lactogen, which is like prolactin, and it will start producing the woman's pregnant mother's breasts will start getting bigger and start producing more milk secreting tissue. So the placenta is telling the pregnant mother to start making milk with this placental hormone that's a lot like prolactin. It also makes something called alpha-fetoprotein, and the main claim to fame on alpha-fetoprotein is if it's excessively high in amniotic fluid. So if you do an amniocentesis and take out a little sample, it can indicate neural tube defects. This is what they use to determine if the baby is likely to have spina bifida. And that's a spinal cord that doesn't seal and is open to the outside. Unusually low levels will tend to indicate Down syndrome. So alpha-fetoprotein is a substance that is produced in the amniotic fluid that can tell you about a couple of birth defects. So now mom is pregnant. So what does she have? First thing, she blocks some of her insulin receptors, and it makes her blood sugar go up. It's diabetes of pregnancy. A lot of pregnant women actually become diabetic during the pregnancy because you're keeping your blood supply high, your sugar supply high in your blood, so you have plenty to give to the growing fetus. So it's an intentional effect to raise your blood sugar during the pregnancy so you have plenty of glucose to feed the fetus. In some women, it stays high forever, and they become diabetic after the pregnancy. Pregnancy is not for weenies. It's not for wimps. It can be good for females in a lot of ways, but it also is highly stressful on the system and can lead to a few problems too, besides just the stress of childbirth itself. Heart rate, stroke volume, cardiac output increased by about 30%. Respiration to match it goes up about 30%. So you breathe deeper, your heart beats faster, it squeezes harder, your blood volume goes up. You retain water so that you have more blood, and you pump that extra blood to feed the fetus. So, everything goes up about 30%. You see that? 30%, 30%, 30%. Respiration, heart rate, stroke volume, cardiac output. Thyroid hormone goes up. Your metabolic rate goes up 30% or so. Your increased metabolism helps sustain the heart rate, and stroke volume increases and breathing increases. So you have hyperthyroidism during pregnancy too. That's sometimes it causes enough stress on the thyroid gland that once you're done with pregnancy, you become hypothyroid for the rest of your life. Some women, a relatively small number, but not super small, wind up with hypothyroidism after the pregnancy is over. Your immune response goes down, so you won't reject your fetus. So temporarily, you're actually more at risk for getting colds and things. Then late in the pregnancy, cortisol will increase, which is your stress hormone, and placenta will start reaching a cortisol releasing hormone, and it causes you to increase oxytocin production, which can cause childbirth to start. So we'll talk about that. So here, your placenta, it's been making placental lactation, so the mom is making milk. It's producing HCG so that you maintain the endometrium, keep your progesterone levels high. And then it starts making corticotropin releasing hormone or cortisol releasing hormone, just like your hypothalamus would. And it makes you produce more cortisol, which increases the amount of oxytocin you make. And oxytocin causes contractions. It's a muscle contractor. When you contract, it causes more stress, so you make more cortisol, which gives you more oxytocin, which makes you contract, which causes more stress and gives you more cortisol. It's a positive feedback mechanism until finally childbirth takes place. So parturition is another term. There's about 8 different terms for childbirth. If you ever take medical terminology, you'll learn all of them. But parturition is the process of childbirth. The mechanical stimulation from the uterus. It contracts once, it hurts, it adds stress, and it causes more cortisol release, which causes more oxytocin release, which causes more contractions. It tends to happen at night. Evolutionarily, it was better not to have a baby out in broad daylight when the lions and tigers and bears, oh my, can see you. So you'd hide someplace in the middle of the night and have babies. So still, most childbirths happen between midnight and 5 a.m. I was born at 1:30 in the morning. Stage 1, dilation of the cervix, the loss of the mucus plug in the cervix, and the rupture of the amnion. And we, in my last class, we had a birthing center close by, and one of our students worked there, and so we got to go in and see ultrasounds and babies moving around and stuff, and it was always pretty cool. And she said, it's kind of you're misinformed if you think your water will always burst. Generally, you get to the birthing center or the hospital or whatever, and at some point they have to actually rupture the amnion for you so that the fluid comes out and the baby can be born. Stage 2, the delivery of the baby. Stage 3 is delivery of the placenta, which, remember, was created by the baby itself, so it's actually part of the fetal material comes out. And then in 6 weeks or so, everything involutes. In other words, everything goes back to the size that it used to be. Another friend of mine who had her first baby said that the nurse said, try something. Right after she delivered the child, the nurse said, try pressing on your abdomen. It is so displaced in there, you can push all the way through and feel your backbone. And she was able to do that. Lactation is the production of milk. Lactose is milk sugar. Now you remember these milk secreting cells are actually sweat cells that are stimulated by prolactin and other hormones, estrogens and things, to differentiate to the point where they can not only secrete fluid, but also can secrete fat and proteins to produce the milk. So you have these lobules. A lobule is a fairly big structure, and it is full of these lacteals or alveoli. And the alveoli are little balls of cells with a hole in the middle, and they secrete milk into the hole here, and it goes out through the lactiferous ducts, which take it all the way to the tip of the nipple. So the duct work will cause, there's little tiny holes in the nipple that are the end of these lactiferous ducts. So the lobule filled with the alveoli secretes milk into the lactiferous ducts, and it comes out through the nipple. The areola around the outside is a muscular structure that can help squeeze and push the milk out so the baby can get it better. The mammary gland develops with prolactin and this placental lactogen, or placental version of prolactin. It matures the breast, makes more of these secretory cells, more of the alveoli, more of the lobules, and the breast grows larger. Oxytocin, being a muscle contractor, is responsible for causing the milk to come out. So one causes you to make it, one causes it to let out. So the same oxytocin that causes uterine contractions during childbirth causes what's called milk letdown, or a movement of the milk from the alveoli out the end of the nipple. The first milk that comes out is called colostrum, and it's almost clear. It has a lot of high protein, but not much fat, because the baby's digestive system can't deal with fat yet. It has a lot of mom's antibodies to help prevent illness. So drinking this colostrum, breastfeeding at that age is important for the health of the baby. For about 5 days or so, you have this watery milk, and then it transitions into mature milk, which is high fat and low in protein. The fat needed for the growth of the tissues, especially the neural tissues, really need fats to grow. Remember, we have the hypothalamus, which secretes oxytocin from the posterior pituitary. So it is a neurohormone. It causes milk ejection. The anterior pituitary is secreting prolactin. I mean, the baby's born now, so you don't have any placental prolactin anymore, or lactogen. So you've got to get it from your own pituitary. So the prolactin is making the milk, the oxytocin is causing it to eject. And the stimulation of both, but especially oxytocin, can come from thinking about your baby, from hearing them cry, from touching the baby, or having the baby suckle at your breast. The sensation sends back signals that causes more oxytocin release and causes you to squeeze out more milk for the baby. And finally, a couple things about neonatal physiology, just barely a touch on it. You could do a whole semester on this, but we'll just talk about a few things that happen. First of all, they have a real high cardiac output for their size. Their heart and respiratory rates are really high. Their blood pressure is low. The blood vessels are really soft and stretchy. You have 55/30 when they're born, 80/50 later. 90/60 after a few months. That's still pretty low blood pressure, considering that you're having a really high cardiac output. The heart rate can be 150. It's not unusual. You don't think your baby's dying because their heart rate's really high. It's supposed to be like that, like a hummingbird. Respiratory rate. In adults, it can be like 12 to 20. In a neonate, 35 to 45 per minute. Metabolism, really high. High lactic acid production because of the high metabolic rate. They initially have a problem forming plasma proteins. They have a problem with their liver function because it's so immature, and they might wind up developing jaundice at first for a little while until they can start getting rid of the bilirubin in their red blood cells that have been filtered out. They're not making much surfactant, so if they're born premature, they can't breathe on their own very well. Thermoregulation is poorly developed, so you have to make sure that you don't overheat or overcool them because they can't regulate their own thermoregulation well. And they may, because the mom had a big burst of prolactin and stuff right before childbirth, and at childbirth the progesterone goes down so you can actually have childbirth, and the estrogens go up. So estrogens, and especially prolactin for the mother, also affects the baby, and the babies are sometimes born leaking milk out of their breasts. And this can be male or female, and it can go on for a couple of days. The other thing about babies, or fetuses, before they're born, we talked about this a little bit in the cardiovascular section, but fetuses have a couple of really big differences compared to when they're born. First of all, they have the umbilical circulation. It's coming from the placenta. The placenta is close to mom's circulation, so it's getting food and oxygen. So the placental circulation brings blood back to the heart that is already oxygenated, so it doesn't need to go through the lungs. It wouldn't help anyway. There's no air in them. So there are two means. There is a foramen ovale. This is a hole between the right and left atria that lets the blood go straight over into the left side to get pumped out to the body. You also have a blood vessel that goes between the aorta and the pulmonary artery called the ductus arteriosus, and it takes blood straight from the pulmonary side. If it's going this way at that time, it takes it from the pulmonary side over here because it's already oxygenated and you want it to get to the baby. It's not, you have a lot of resistance to blood flow through here anyway because there's no oxygen in there, so all the blood vessels are constricted. So that allows this blood to move across into the general circulation that the baby needs. When you're born, you take your first big breath, and suddenly these blood vessels all open, and the resistance drops, so now blood can go this way. The pressure drop here, because of that, causes there's a flap that snaps shut and closes the foramen ovale. It should stay shut for the rest of your life. Some people wind up with a flap that never grows shut. It just generally stays shut because pressure on the left side is higher than the right side in an adult. But it can be what's called a patent foramen ovale, meaning it still will open, which is not bad, except under certain circumstances, like scuba diving. It can cause you problems, but generally people never know it. Okay, but that foramen ovale is supposed to stay shut. Otherwise, you can surgically close it. And the ductus arteriosus, taking the blood over here into the aorta, the reversal of blood flow in it causes a reaction, and it causes it to pinch shut and eventually disappear. So in almost everybody, within a short time after they're born, no blood flows through the ductus arteriosus anymore, and in an adult it's gone altogether. If you wind up with a patent ductus arteriosus after, a few weeks, you won't be oxygenating your blood very well, because now you have deoxygenated blood coming back and making its way into your aortic blood. That's not good. You don't want to mix it. You want it to go to the lungs. So you have to surgically close that patent ductus arteriosus. So a patent foramen ovale or a patent ductus arteriosus, meaning they're still working, is not good in an adult. You need them in the fetus, but you need not to have them as an adult. And that's it for the lectures for A&P2 this semester.